Good morning, and welcome to this meeting of the Physician-Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Lauren Harden, and I'm one of the co-chairs of PTAC, along with Dr. Angelo Sinopoli. As you may know, PTAC has been looking across its portfolio to explore themes that have emerged from proposals received from the public over the years. Topics the committee has covered include telehealth, social determinants of health, and care coordination. In 2021, the Innovation Center at the Centers for Medicare and Medicaid Services released its strategy refresh for the next decade. One of CMS's objectives is to drive accountable care with the goal of having all Medicare beneficiaries in a care relationship with accountability for quality and total cost of care by 2030. To support that goal, PTAC's public meetings last year examined key issues related to developing and implementing population-based total cost of care models. We will release our report to the Secretary with our findings from that series this month. One theme that emerged from those discussions was how to integrate specialists into population-based models, which PTAC has decided to explore further. We appreciate that CMS has engaged with us on this important topic. This morning, we are honored to have opening remarks from Dr. Liz Fowler, the Deputy Administrator of CMS and Director of the Center for Medicare and Medicaid Innovation. Dr. Fowler previously served as Executive Vice President of Programs at the Commonwealth Fund and Vice President for Global Health Policy at Johnson & Johnson. She was Special Assistant to President Obama on Healthcare and Economic Policy at the National Economic Council. From 2008 to 2010, she also served as Chief Health Counsel to the Senate Finance Committee Chair, where she played a critical role in developing the Senate version of the Affordable Care Act. Welcome, Liz.
Thank you, Lauren. Thank you, Dr. Sinopoli and others on PTAC. It's really a privilege to be here and provide opening remarks at your quarterly public meeting, and just great to be in person. First off, I want to share our excitement that specialist integration within population-based total cost of care models is the focus of the March 2023 PTAC public meeting. The CMMI Specialty Care Integration Team will be live streaming the public session, and I see Dr. Jake Quinton, our medical officer who's leading this effort, is here in person, as well as Linda, who supports this work as well. So we are here because we firmly believe that this is going to be a really exciting set of discussions today and tomorrow. And I look forward to hearing a report out of the robust and informative discussions, even though I won't be able to stay for the entire meeting. The theme of your meeting is clear evidence that we're very well aligned in our areas of focus. And many of the themes and topics you're set to discuss are questions that we're also grappling with in our own work. And looking at the list of speakers you've invited, I see some familiar names, so we're talking to some of the same experts, so this is a really good sign. 2023 is shaping up to be an exciting year for the Innovation Center. Already, we published a report last month in response to the executive order on lowering prescription drug costs for Americans and launched the new ACO REACH cohort. In the report, the drug pricing report, we identified 3 new prescription drug models to consider testing and 3 areas for additional research. And this year, if all goes according to plan, the Innovation Center plans to announce 3 to 4 new models on advanced primary care, population and condition-specific accountable care models, and a state total cost of care model. In terms of what you can expect from these models, in our continued focus on addressing health equity, they'll include a focus on underserved populations and make it more possible for more safety net providers to participate. We will also continue to focus on strategies to drive better integration of primary and specialty care to serve those with chronic or serious conditions through our models. And by keeping a focus on patients in the Innovation Center models, we can improve the way care is delivered, align payment incentives across the system, and ultimately improve outcomes. Given the topic of today's meeting, I'd like to speak a bit more about our specialty care strategy. In June last year, CMS published a paper titled Pathways for Specialty Care Coordination and Integration in Population-Based Models. And in November 2022, we published another paper, the CMS Innovation Center's Strategy to Support Person-Centered Value-Based Specialty Care. Since the release of our specialty care paper, we've been conversing with many interested parties, both internal and external to CMS, and digesting a lot of information, identifying challenges, and brainstorming about possible model design approaches. As part of the specialty care strategy shared in the paper in November 2022, we're exploring ways to increase data transparency and expand the data provided on specialists to facilitate and better encourage engagement in referral decisions. We recently conducted a survey of ACO and primary care group practice participants, organizations in the Medicare Shared Savings Program, ACO REACH, and Primary Care First, to solicit feedback on their interest in receiving new forms of data to support specialty engagement. We'll use these survey responses to guide our plan to expand data sharing. Our first objective in offering better information on specialists is by providing shadow bundle data to ACO participants. This data, including claims data constructed into episodes of care and provided alongside target prices for attributed beneficiaries, will allow an ACO to analyze spend and care patterns for specialists, as well as offer a new way to engage with specialists. In February, we released the Bundled Payment for Care Improvement Advanced, or BPCIA, Advanced Request for Applications, and opened the application portal for participation during a 2-year extension in 2024 and 2025. We'll be accepting applications until May 31st, 2023, and actively encouraging Medicare providers, suppliers, and ACOs to apply. Additionally, we're thinking about the future of episode-based payment models with a focus on creating a model that is complementary to ACOs. We intend to engage interested parties for their input of a future model with a request for information during the third quarter this year. As we refine our thinking and consider questions to pursue in the RFI, as we call it, the request for information, it really comes back to the basics. What are the current challenges related to specialty integration in advanced primary care models and ACOs? What are the barriers to integration? What strategies and approaches would best support increasing specialty care provider engagements in ACOs, where specialists share accountability with primary care providers for high-value care and bearing appropriate financial responsibility for patient outcomes? How should high-value specialty care be defined, and what are the appropriate performance measures for assessing specialty integration? We hope that our partnership with PTAC will help inform the answers to these questions. And maybe with that, I'll stop, and I wish you all a very productive meeting. Thank you.
Thank you so much for joining us today, Liz. We really appreciate your comments, and we really appreciate working together with your team. Thank you. So for today's agenda, we will explore a range of topics, including best practices for structuring coordination between primary care providers and specialists, how advanced primary care models and ACOs can improve specialty integration, structuring financial incentives and performance measures, and how to address the unique challenges that safety net providers and rural providers face. We have background materials online on these topics, and over the next 2 days, we will hear from many esteemed experts on these topics. We've worked very hard to include a variety of perspectives throughout the 2-day meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed models. I want to mention that tomorrow afternoon will include a public comment period. Public comments will be limited to 3 minutes each. If you would like to give an oral presentation tomorrow but have not yet registered to do so, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. The discussions and materials and public comments from the March PTAC meetings will all feed into a report to the Secretary of HHS on how to improve specialty integration and population-based total cost of care models. The agendas for today and tomorrow include time for the committee to discuss and shape our comments for the report. Before we adjourn tomorrow, we'll announce a request for input, which is an opportunity for stakeholders to provide written comments to the committee on today's topic. Thanks for joining us, Liz. Lastly, I'll note that, as always, the committee is poised and ready to receive proposals on possible innovative approaches and solutions related to care delivery, payment, or other policy issues from the public on a rolling basis. We offer 2 proposal submission tracks for submitters to provide flexibility depending on the level of detail about your payment methodology. You can find information about how to submit a proposal online. At this time, I would like my fellow PTAC members to please introduce yourselves, share your name, your organization, and if you would like, a brief word about your experience you have with our topic. First, we'll go around the table, and then I'll link to our members that are on Zoom. So I'll start. I'm Lauren Hardin. I'm a nurse and Vice President and Senior Advisor for National Healthcare and Housing Advisors. I've spent the last 20 years engaged in care management, innovation, and value-based payment for underserved and vulnerable populations.
Thanks, Lauren. So I'm Angelo Sinopoli. I'm a pulmonary critical care physician by training, presently the Chief Network Officer for Upstream, which is a company that provides support for primary care physicians engaging in value-based care. Prior to that, I had several decades of experience building very large networks for Prisma Health as my last employer with a very large network, and developed a freestanding enablement company called Care Coordination Institute that housed all of the care coordination, process improvement, expertise, et cetera. So.
Good morning. I'm Jennifer Weiler. I'm the Chief Quality Officer for UC Health Metro, one of the largest healthcare organizations in the Rocky Mountain region. I'm a tenured professor at the University of Colorado School of Medicine, and I am trained as an emergency physician. I'm also the co-founder of UC Health's Care Innovation Center, where we partner with digital health companies to grow and scale their solutions focused on high-value care. I'm also a co-author of an alternative payment model that was reviewed by this committee and considered by CMMI.
Good morning, everyone. My name is Josh Lau. I am an internist practicing Seattle at the University of Washington, where I'm also an enterprise medical director working on payment strategy, population health, and value-based care, and covering a range of topics, including specialty integration that we'll talk about today. Outside of that, I'm also fortunate to lead a national group evaluating payment and care delivery policy and research.
Good morning. My name is Jim Walton. I'm a retired internist, recently starting a consulting firm after retiring as a CEO of Genesis Physicians Group, which was a 1,500-member IPA in Dallas, Texas, and started an ACO there that's been working with CMS. Prior to that, I was the Chief Health Equity Officer for the Baylor Healthcare System, and I'm just glad to be here.
Good morning. I'm Walter Lin. I'm an internist and founder of Generation Clinical Partners. We are a medical practice specializing in the care of the frail elderly living in senior living, particularly nursing homes and assisted living facilities. And I have a special interest in specialty integration and engagement in end-of-life care.
Good morning. I'm Lindsay Botsford. I'm a market medical director with One Medical. I'm also a family physician with IORA, together with One Medical, which is our Texas practices that care for older adults on Medicare. We care for older adults in full risk contracts with Medicare and Medicare Advantage plans, including our ACO REACH products.
And now I'll turn to our members who are joining remotely. Chinny, please go ahead.
Good morning. Chinny Puluro. I'm a family physician by trade. I serve to lead clinical operations within the Walmart Health business. I also am the chief clinical executive of the Walmart Health enterprise. I previously ran and sort of led a large medical group through value-based care transformation and led all things care delivery. Value-based care transformation included taking a group through all risk patterns, a multi-specialty group, the entire risk spectrum into total cost of care programs. And so I have a particular interest in specialty integration because it was a large part of our value-based care work in my previous world.
Thank you, Chinny. Larry, please go ahead.
Good morning, everyone. I'm Larry Kaczynski. I am a gastroenterologist and spent the majority of my career in private practice in the northwest suburbs of Chicago and helped build the largest single specialty gastroenterology practice in Illinois. Currently, I am the founder and chief medical officer of Sonar MD, a value-based care company focusing on specialty care in the digestive disease space. And it was started as an offshoot of a successful PTAC proposal back in 2017. So I'm heavily engaged in specialty care integration into risk-based contracts and look forward to these next 2 days. This should be good.
Thank you, Larry. And Jay, please go ahead.
Good morning, everyone. My name is Jay Feldstein. I'm currently the president and CEO of Philadelphia College of Osteopathic Medicine. I'm trained as an emergency medicine physician, and prior to this role, I spent 15 years in the health insurance world in both the commercial, Medicare, and Medicaid space, in the last 3 years running 5 Medicaid plans in 5 states, and I'm very familiar and interested in integrated and value-based purchasing models.
Thank you, Jay. And one of our members couldn't attend today, Lee Mills, who has been very key with development of the materials for our session today, is a physician that leads an ACO in Oklahoma. So we have a very rich meeting today. Let's turn now to our first presentation. 5 PTAC members served on the Preliminary Comments Development Team, or PCDT, which has worked closely with staff to prepare for this meeting. Jennifer led the PCDT, with participation from Larry, Chinny, Jim, and Lee. I'm very thankful for the time and effort you all put into organizing, preparing, and really thinking deeply about this topic and the materials for this agenda. We'll begin with the PCDT presenting some of their findings from background materials. These are available on the ASPE PTAC website. PTAC members, you will have an opportunity to ask questions and follow-up comments after the presentation. So now I'll turn it to the PCDT lead, Jen.
Thank you so much for the opportunity for us to tee up what we think is going to be a really interesting and important 2 days. As was described, I had a phenomenal group who helped to develop the materials in front of you. And really what we're hoping to do today is to give a brief overview and background about what is the current state and what are some challenges related to this topic. And then we're really looking forward to the next 2 days of having our experts come and discuss with us some of their theoretical approaches or the practical application of these principles, where there have been successes and where there may have been some challenges. Before I start, not only do I want to thank our work group, again, Larry, Lee, Chinny, and Jim, but I really would like to thank on behalf of our group, the ASPE staff, PTAC staff, and NORC, who were instrumental in putting our presentation together today. So the objectives of our theme-based meeting are to really focus on how do we increase specialty care provider engagement in population-based total cost of care, where specialists share accountability with primary care providers in providing high-value care and bearing appropriate financial responsibility for patient outcomes. What we hope to do is examine issues related to improving care delivery and specialty integration in these population-based models. What we will consider is structuring and improving the coordination between primary care and specialty care providers within existing advanced primary care models, and also within the construct and outside of the construct of accountable care organizations. We look to identify best practices for defining and, where appropriate, nesting specialty episodes in these population-based models. We'd like to talk about determining attribution, the structuring and financial incentives, selecting appropriate performance measures, and also we think it's important over these next 2 days to think about how do we increase the participation of safety net and rural providers, and also those who are not in large group practices, but in small independent practices. So the background for this theme-based meeting includes, in September of 2022, we had a public meeting that covered payment issues related to population-based total cost of care models. Our committee has deliberated on the extent to which 28 proposed physician-focused payment models, or PFPMs, have met the Secretary's 10 regulatory criteria, and that includes integration and care coordination, which we believe will be a key theme throughout this meeting. Many of these proposals that this committee has reviewed and evaluated raised issues and challenges with regards to specialty integration. And ultimately, our goal for this meeting is to better understand these challenges and how various experts and providers have sought to address them. We'd like to offer a preliminary working definition of the characteristics of specialty integration in the context of value-based care. And we think this asterisk is actually the most important point on this slide. And that's that we think that this is should be a working definition, and that based on our conversations over the next 2 days, we'd like to refine this recommendation. So specialty integration is a desired characteristic of population-based total cost of care models. That's why we're here today. And what we believe our characteristics include that primary and specialty care provider roles and responsibilities, individually and collectively, are clearly delineated throughout a patient's care journey for a given condition or episode of care. It assumes that specialty care includes a continuum of responsibilities for a patient or condition that includes but is not limited to a single consultation, co-management, and primary management, which we'll talk a little bit more about. Primary and specialty care providers should coordinate to provide patient-centered care using bidirectional, synchronous, and asynchronous communication. Specialists should provide consultations and or ongoing care through multi-modes, including those I just previously described, and those should be provided in a timely manner. And we believe that primary and specialty care providers have access to use shared real-time data to inform care and decisions. And why we think these characteristics are so important is because we're also interested in how do we incentivize these types of activities to occur. We'd like to offer up the refinement of this model that has been previously developed around what the design elements should be for consideration of specialty integration into population-based models. So briefly, let's start over on the left. With regards to management, I just mentioned a couple of these potential characteristics, but in the domain of management, the considerations are a consultation or a referral, what the relationship looks like from a co-management perspective, where there may be shared management or co-management with principal care, either by the primary care provider or the specialist, or a specialist principal management. The other element for a model design is attribution. We hope that our experts will help us to dive deeper into this topic of attribution. But briefly, attribution could be patient-described or self-reported. It could be based on visits for preventative care or wellness. It could be based on primary care visits, prescription data, E&M codes, or other methodologies that we hope our experts will help us to better understand. Data sharing and communication is another important characteristic and element. I talked a little bit about that before. And then another consideration that we think is important is financial accountability. There are a number of different models. Again, over the next 2 days, we hope to dive deeper into this. But these include the current fee-for-service mechanisms where there is no accountability that is shared. There are models where a non-specialist model entity has voluntary or mandatorily shares risk with participating specialists. And specialist model entity assumes risk in voluntary or mandatory models. And there's many other options, but those are just a representative example. Now, what we think is important is to call out in each of these elements, there are additional characteristics that may affect these model elements that are important and may also impact their interrelationship. One that we think is the most important are patients with multiple chronic conditions. According to a 2018 report, almost 70% of Medicare beneficiaries have 2 or more chronic conditions. So how do we take that into consideration when we're talking about nesting of specialist models? The condition or procedure type and severity of the patient's condition is a consideration. Where a provider is located and care is delivered, urban or rural. Cooperative agreements between entities potentially under or outside of an ACO umbrella. An organization type, ACO or other. What the financial viability is of the practices that are participating. The provider employment status, we think, is an important characteristic for consideration. What the prevailing market conditions are. And then specifically with regards to data, the data quality and infrastructure for sharing. So what we noted is that there are specialist roles in delivering care in coordination with primary care providers that may differ. And so we thought this was a easy way for us to start considering what are the different types of care delivery models, and then ultimately how payment policy may be affected by these care models. So we want to propose this as a recommendation for the committee to consider. The first is the duration of the specialist involvement, which may be brief and limited or extend into comprehensive continued management. And also, but different, importantly different, is the extent with which a specialist is involved. So if we are to think about this as a continuum, we may think first about a pre-consultation exchange where physicians interact to discuss the care of the patient, which then could escalate into a traditional consult where a patient is evaluated by a physician. As this progresses, there could be co-management with shared care of either an acute condition or a chronic condition, but the principal management is by a non-specialist, and typically this is a primary care provider. In other conditions, patients may require co-management for either an acute or chronic condition, but really there is a shared responsibility for the care of a patient, both by the specialist and a primary care provider. And then there are disease states or conditions where the principal management for the duration of care, maybe a care episode, is primarily driven and performed by a specialist as opposed to the primary care provider. We thought an example of this may be helpful to show what a continuum may look like. And the example that we give is a patient with renal disease. So in a pre-consultation exchange, again, physician to physician, potentially a primary care provider would discuss with a nephrologist advice on the diagnosis and care of a patient who has both diabetes and hypertension, which, as we know, are conditions that place a patient at high risk for chronic kidney disease and end-stage renal disease. It may then escalate that there is a need for a traditional consultation where the patient sees the specialist. A primary care provider, for instance, would request this consultation from a nephrologist for a patient whose estimated GFR indicates that they are now progressing to chronic kidney disease. Should the patient's clinical condition continue to escalate, or in this case deteriorate, what might be appropriate next is that the specialist has co-management responsibilities and shared management with a primary care provider. So let's assume the primary care provider provides episodic assessments of a patient with stage 3 or higher kidney disease, and the nephrologist continues to follow up on the GFR or eGFR, which unfortunately in our example continues to decline. And then finally, as the patient's clinical condition continues to deteriorate, the nephrologist may oversee dialysis treatment and management of a patient who progresses to end-stage renal disease, where the primary care provider is still coordinating screenings and preventative care and manages other conditions, but the nephrologist is the person who's primarily responsible for the kidney treatment. And so in this case, the specialist co-management is really for principal care of a chronic condition. And I think this is an example that's familiar to many. So what are the potential criteria for categorizing specialty conditions or disease conditions by appropriateness for episode-based payments? We think that there are a couple of important ones. The first is the criteria for identifying specialty conditions that may be more appropriate for bundled episode payments. These may include specialty-driven, or conditions that are generally managed procedurally, or those where there is low variation in spending. And I think if we look across the Medicare portfolio and the CMMI portfolio currently of programs, those conditions crosswalk to these characteristics. The second criteria for identifying specialty conditions that may be more appropriate for a per member per month or PMPM chronic disease management payment may be those that are generally managed cognitively or non-procedurally and may involve shared management with a primary care provider. Again, we think these are important clinical and care management distinctions that we then should consider how they correlate to payment policy. We thought we would provide here a clinical example where this may be germane and actually show even within one medical subspecialty the variety of disease conditions, their occurrences, and then how this might relate to payment policy. And I'd like to turn it over to Dr. Larry Kaczynski, who is expert and going to give us an example from the gastrointestinal disease space. Larry.
Thank you, Jen. This slide was created to represent as a single view the results of a study we ran with the assistance of a major commercial health plan to demonstrate the differences between the major conditions in one specialty, gastroenterology. It was published in 2020 in the journal Gastroenterology. To generate the data for this study, we provided the health plan with the ICD-10 codes for the major GI conditions, and the health plan then calculated the total cost, disease-specific cost, and cost per decile for each condition. If you look at the figure, the disease-specific cost compared to the total cost is represented on the horizontal axis as the percent disease-specific cost. The vertical axis represents what we call the beta rating for each condition. This beta rating was calculated in a similar fashion to how a beta rating is created in the financial industry for the analysis of the volatility of a stock portfolio. In this case, it is the standard deviation of the cost per decile and represents the variation of each illness against the index for all GI conditions. Just as individual stocks in a stock portfolio have different tendencies to change their value against a stock index, so also do diseases when compared against an index for a portfolio of specialty-specific diseases. In our case, this represents the variation in cost per patient for the specific condition as compared against the variation of cost per patient for the entire GI index. We thus create a beta rating for each condition, which is represented on the vertical axis. The bubble bubbles for each condition are thus displayed on the figure as a plot of their beta rating against their percent disease-specific cost. Those conditions that are clustered in the lower left have lower disease-specific cost and lower volatility. Those in the upper right have higher disease-specific costs and higher volatility. We further add depth to the analysis by varying the size of each bubble by the actual disease-specific costs for each condition so that the overall cost per patient can be compared by disease. Finally, we profiled each condition with respect to how much of their cost was driven by cognitive services versus procedural services so that we can create a payment model for each. This is reflected by the level of shading of each of the bubbles. The analysis demonstrates the following conclusions. Number one, the overwhelming majority of disease-specific costs and variability of costs for the GI space is driven by the two inflammatory bowel diseases, Crohn's disease and ulcerative colitis. The remainder of the GI conditions cluster around the GI index. Inflammatory bowel disease should therefore be a major focus for specialty payment models for gastroenterology. This analysis can also be used to determine payment methodology. Conditions like colon polyps, which are mostly procedural and have minimal disease-specific cost and low beta rating, are best managed through bundled payments. Conditions like irritable bowel syndrome and celiac disease, which are cognitive but also have low disease-specific cost and beta rating, are best managed through PMPM payments. Conditions like IBD will require a blend of per member per month payments for cognitive services and bundled payments for the occasional procedures that are necessary. Finally, we believe that GI is not unique and that this same methodology can be used in most other disease categories and specialties. Thank you, and I'll turn it back to you, Jen.
Great, thank you, Larry. So we think this is an exceptional example, again, from a specialty that manages a broad variety of diseases, both that are treated and evaluated through cognitive work, and then also evaluated and treated through procedural work, and how to think about both, again, care model and payment model. So thanks, Larry, for allowing us to use this excellent example. And again, as Dr. Kaczynski said, we think it's an analysis that may lend itself well to other specialties for which to make a consideration. There are a number of payment design features that help support specialty integration that are currently within the Innovation Center portfolio. These models use nested specialty care and payment and include, as Larry was just describing, a couple of different payment tactics. Those are bundled payments, per beneficiary per month payments, and then ultimately capitated payments. The bundled payments appear to be best applied to conditions that have low variability, as we just discussed. And here's a list of a number of the current models in the innovation portfolio. Again, thanks to staff in our landscape assessment in the appendices, there's a lot of important detail supporting this information. The per beneficiary per month payments may be more appropriate for chronic conditions. They can cover care management and coordination activities without adding separate fee-for-service based charges for non-procedural services. Again, the number of different models in the portfolio, including the next-gen ACO models, which are representative examples. And then capitated payments, which to date, research has tended to focus on chronic conditions and oncology care, but what we noted is that the results are currently mixed with respect to the efficacy of these types of programs. So what we'd like to do now is summarize what we believe to be are a representative list, and certainly not a comprehensive list, of the care delivery challenges related to improving specialty integration in population-based total cost of care models. How we chose to break these out are things that our committee talks about often, and that is the important interplay between a care model and a payment model, which are different, but obviously intricately aligned. And so we thought we would specifically call out some of those challenges first in the care delivery model. The first is defining the roles of primary and specialty care providers at various stages in the patient's disease progression and including potential overlap between specialists. We already gave you a representative example of a renal disease patient, but another example where overlap may occur is advanced heart failure, where a patient may be a heart transplant candidate, for instance, and there's a lot of overlap if that patient ultimately is escalated to transplant. Number two, defining and measuring high-value care. We'll talk about that more in upcoming slides. Number three, clinical care pathways to support patient-centered care. What we note is the challenge is around availability. What is the existing evidence around what is best practice from a care delivery perspective that is condition-specific? Number two is around timing. So when a primary care provider should engage a specialist or make referrals. And again, there are those environmental factors which come into play, availability of resources, for instance. The care management continuum, the extent and duration of co-management between primary care providers and specialists. And then again, overlaying all of this are resources. So what are the existing assets, or what are the access to assets that help support the provision of evidence-based care? It may be evidence-based to obtain an MRI for a certain condition, for instance, but if in a rural community they don't have access to that advanced imaging, then there need to be different considerations. So number four is not only limited access from a clinical care pathway perspective, but ultimately limited access to certain specialties. Again, this may be in rural communities, but there may be actually a deprivation of resources within urban communities, and that may be availability may also be impacted by a patient's insurance status. And then number five, another challenge from the care delivery model perspective is data, both sharing and quality of data. So there's varying levels of data access and coordination between primary and specialty care providers and across various care setting. And there are high resource needs that this committee has previously heard about, and I think over the next 2 days we will hear more about, but with regards to developing not only the infrastructure for data sharing and the relationships for sharing, but also really definitions and understanding about what high value data exchange looks like. So the challenge is really ultimately defining what is ideal care, or as I like to say, perfect care that is high value. So there were two other considerations that we thought were important to surface here in terms of our landscape assessment, and that's first the specialty visit duration. One of the challenges is in the fee-for-service environment, it may encourage specialty providers to increase their patient volume, seeing more patients per day and spending less time with patients at each visit. I think we all know that that is a current incentive. However, it may be true that in contrast, for a specialist to see fewer patients and spend more time with each patient could ultimately support measurable care improvements. So these longer visits may support improvements in diagnostic decision-making, the patient-provider relationship, ultimately patient engagement, trust, care management, and then ultimately lead to an improved outcome. And one example may be in a procedural space like an orthopedic surgeon who may be incented to do procedures and surgery in the current fee-for-service environment, however, not as encouraged to spend time coordinating care with an athletic trainer or a physical therapist to really try to create a non-operative optimization of a patient to prevent or avoid or delay surgery. Another challenge is front-loading of care. It may be that higher frequency or higher intensity visits, medical or surgical, earlier in a care episode may prevent escalation of disease and then ultimately utilization and cost. So one example we wanted to highlight is that research shows that cost and utilization and quality outcomes over time for end-stage renal disease patients, when dialysis is required, it may be high value to just place a fistula or a graft as opposed to starting with the interim state of placing a catheter, for instance.
Jen, I'm just going to give you a 5-minute.
Perfect. Thank you. So there are some considerations with regards to data sharing that we think are important. And one of the most important to highlight is the variation in how providers use and share data. Ultimately, providing patients with price transparency is something we'd like to hear more about over the next 2 days. How do we create policies that help to incent data transfer? And what are those current challenges? And how do we ensure that the appropriate data is transferred with regards to our consultation process? I've summarized briefly what are the opportunities from a care model perspective, and now I'm going to transition into payment model. The first is currently there is insufficient financial incentives for encouraging specialists to move into value-based care. We heard about this at our last meeting. Liz Fowler talked a little bit about this in her opening discussion about where there are opportunities, and we really think this should be the focus of our next 2 days, how to think about incentives, financial or not, to incent participation of specialists into total cost of care models. We recognize that identifying attribution models that are most appropriate for both primary care and specialists is important and a big challenge. There's also a challenge around the amount of flexibility that accountable entities should have in deciding which conditions and episodes should be nested, and then how to structure incentives, including financial incentives. There's also a challenge identifying specialists and conditions that are most appropriate for nesting within these models, and whether certain specialties should or should not be included in total cost of care models, which I think we'll be interested to hear more about those groups maybe that should be excluded. The arrangement for structuring payment models, we will be interested to hear more about provider level risk and entity level risk and what those incentives may look like. And then ultimately, there's a challenge of participation of safety net and rural providers or low volume providers. And then there's a challenge around creating meaningful benchmarks for evaluation of high value care. In each of our subsequent slides, we go into details of each of these challenges, but I think with respect to time, I'll skip over some of those details because I know we had those materials available to us before. But again, to summarize, challenge one is that there are insufficient financial incentives for encouraging specialists to move into value-based care, and these are a lot of the drivers that we've identified related to that challenge and what currently exists in current state. Challenge two, with regards to attribution models, including timing and duration, for instance. There are already, we will note, the use of beneficiary level attribution models that currently exist, but however, there have been some challenges with their implementation within the current Medicare and Innovation Center portfolio. With regards to challenges 3 and 4, really this is where I think a lot of our discussion will be over the next 2 days, and that's how much flexibility should accountable entities have in deciding both what conditions and episodes should be nested and what the structure of those financial relationships should look like. And again, what clinical conditions are most appropriate for model nesting. Here is just one summary that we think is a nice rubric for us to be thinking about specifics around specialty nesting models. And on our horizontal axis is overall utilization. The vertical axis is spending per episode. And this just shows the variability across different disease conditions. So briefly on the left, there are high specialized but low utilization services. And the example we gave is transplant surgery. There are other conditions where there is low specialist utilization with chronic management. And I think we've given some previous examples here in the presentation. Next are some conditions that are high utilization, but just during an acute management phase. And stroke is an example I think that others are familiar with and that previous APMs have considered. There are also high utilization subspecialty services with a moderate amount of spend, and our example here is cardiology. And then there are highly specialized high utilization services, and a clinical condition might be pulmonary hypertension, for instance, and the total cost may be related to drugs. I'm not going to go into too much detail about what the definition is of, what is the rubric for defining a nested model. We actually have some experts who've developed this previously, but essentially for condition episodes, there is a trigger of usually a billing code to define an episode, and then there's an accountable period, which typically is around 1 year. And for procedures, again, there's a trigger of a code, and then there is a predefined end for that clinical condition. Again, I won't go into the details of each of our challenges that we've identified. I think our speakers are going to ultimately extract some of those opportunities, but we did want to mention briefly around creating meaningful benchmarks for high-value care. And although there are a number of programs currently that do this in the oncology care model and others, we think that there is an opportunity for us to better define how we evaluate and create benchmarks, either thresholds or targets for the participation and ultimately the care delivery of specialists and total cost of care models. So our recommendation for the areas of focus for this meeting are how should we increase specialty care provider engagement in total cost of care models where specialists share some or a lot of accountability with primary care providers for providing high-value care, and again, bearing appropriate responsibility, including financial responsibility for patient outcomes. The issues related to specialty integration, both within the current Medicare payment programs and advancing primary care models and within ACOs. What are our approaches for structuring coordination between primary care providers and specialists, which we acknowledge from a care delivery perspective is value added, but how do we create those incentives? How do we monitor them? Potentially, how do we collect data around that? What are the options for defining and embedding specialty episodes within a population-based model, including patients who have multiple chronic conditions? The role of HIT and healthcare information and analytics in specialty integration and what is necessary both from an infrastructure perspective and then ultimately from a data sharing perspective. Again, we want to focus on how do we have safety net providers and rural providers included in these models, and what are the specific challenges? And then ultimately, which may be a discussion in and of itself and may be worth us having an additional meeting, but that's around appropriate performance measures for specialty integration. And with that, I'd like to again thank my colleagues, the NORC staff and PTAC staff, for helping us put together this landscape assessment of what we believe the current state and challenges are.
I want to acknowledge this PCDT. This was an incredibly valuable and rich presentation with some really wonderful visuals as well to summarize complex concepts. Members, I'd like you to jot down your questions or comments because we're going to go right to the break, but please write those down. We'll have an opportunity to discuss later in the day. So at this point, we will take a break until 10:30 a.m. Eastern. Please join us then. We have a great lineup of guests for our first panel discussion on strengthening advanced primary care and improving specialty integration. Welcome back. Jen and the PCDT helped us level set with our goals and our starting point for this public meeting. I'm excited to welcome our first panel discussion. At this time, I ask our panelists to go ahead and turn on video if you haven't done so already. In this session, we have invited 3 esteemed experts to discuss strengthening advanced primary care and improving specialty integration. After each panel offers a brief overview of their work, I'll be asking them questions. PTAC members, you'll have an opportunity to ask our guests follow-up questions as we go. The full biographies of our panelists can be found on the ASPE PTAC website, along with other materials for today's meeting. I'll briefly introduce each of our guests and their current organizations and give them a few minutes each to share an overview of their work. First, we have Ms. Ann Greiner, who's the President and Chief Executive Officer of the Primary Care Collaborative. Ann, welcome. Please go ahead.
Well, thank you so much. It's wonderful to be here, and I very much appreciate the invitation. As you heard, I'm President and CEO of the Primary Care Collaborative, and we are a nonprofit, multi-stakeholder organization that brings together about 70 members from all different sectors, patient groups, all kinds of primary care clinicians and behavioral health folks, purchasers, health plans, pharmaceutical organizations, tech firms, etc. Very diverse, but the common thread is a commitment to strengthening primary care as the foundation of a high-performing health system. I'm thrilled to be talking about this topic about primary care and specialty care and improving coordination. It is very important to patients. When the National Partnership for Women and Families, a member of PCC, did focus groups and asked patients, define patient-centered care, they said care that's coordinated. More recently, the Community Catalyst did focus groups with patients that are 50 and above in underserved communities and asked them, what are you seeking what are you seeking in primary care? And they said a navigator, an ongoing relationship, and one-stop shopping. So I think it really is a very important topic. The PCC has defined advanced primary care with 7 different principles. One of them is care coordination, but we've broadened that a bit. It's coordination and integration, and that's really what patients want. They want their care to be integrated, and for someone to help them navigate. But care coordination is getting a lot more complicated. A 2022 study by Michael Barnett and Asaf Batan found that in 2019, 19% of Medicare beneficiaries had 5 or more physicians. That grew to 35% by 2019. We also know that the clinicians are having to coordinate with a lot more physicians. In 2000, they were coordinating with 52 other physicians. That grew to 95 by 2019. And this is resulting in a lot more fragmentation. 4 in 10 Medicare beneficiaries report highly fragmented care. So what's driving all of this enhanced coordination burden? Lots of things. Patients are less healthy, under fee-for-service arrangements, which most of primary care is still under. Primary care visit time is not adequate to meet expanded patient needs. Consolidation is also a factor. 70% of primary care clinicians work for hospitals or other corporate entities. Many hospitals think of primary care really as referring partners as opposed to providing the kind of time to really manage patients in the primary care setting. And finally, patients can't locate or retain primary care. When we look at usual source of care, the PCC put out a report in 2022 last year, and we saw a 10% increase in loss of usual source of care. About 74% of patients have a usual source of care. That varies widely across states. There's a 27% swing across states in usual source of care. The solution that we believe in, that what we are working on at the Primary Care Collaborative, taking a page from the recent National Academy of Science, Engineering, and Medicine report, is to pay primary care differently and to pay primary care more. A scorecard that came out last week from the Milbank Memorial Fund found that we continue to underinvest in primary care. In fact, investment has gone down in the last 10 years. It was 5.8% in 2010. It's 4.6% in 2020. Capitation levels are in the single digits and also declined during that period. Not to pick on our friends in the dialysis realm, but we spend 6% on dialysis patients and less than 5% on primary care. So what we focus on is changing how much we pay and how we pay, and we can point to a lot of innovators who are investing in primary care, building out primary care teams that are able to manage the multiple needs that patients have with care coordinators, community health workers, NPs, and other members of the team, social workers. Care is less fragmented. You're reducing your care coordination burden. And most importantly of all, you're enhancing patient outcomes, reducing inequities, and beginning to bend the cost curve. So thank you so much for giving me the opportunity to provide those opening remarks.
Thank you so much, Anne. Next, we're excited to welcome back one of the past chairs of PTAC, Dr. Paul Casale, who's Vice President of Population Health at New York Presbyterian, Weill Cornell Medicine, and Columbia University. Paul, it's great to see you. Please go ahead.
Thank you, Lauren, and thank you to all the PTAC for inviting me to come back. Having been a long-standing member of PTAC for a number of years, I know how important the work is, and look forward to the discussion we are going to have around improving specialty integration and strengthening primary care. So I lead population health initiatives at New York Presbyterian, Weill Cornell, and Columbia, which includes a MSSP ACO, which has approximately 40,000 beneficiaries. We have about 5,500 clinicians who are part of our ACO, of which approximately 20% are primary care and over 50% are specialists. So in fact, engaging with specialists is something we think a lot about in our ACO. We've been fortunate. Our ACO has been successful. We've earned shared savings for the last 5 consecutive years. Our quality scores have consistently been over 90%. But having said that, I look forward to the discussion we're going to have around, in particular, engaging specialists. We've had experience both in oncology care model through the 2 medical schools, as well as CJR at a variety of sites at New York Presbyterian. So look forward to further conversation around how that has worked or the challenges around that within an accountable care organization. The other comments I'd make is some of the other work I do, which is As a cardiologist, I'm actually quite active in the American College of Cardiology. I lead a lot of their population health initiatives, chaired multiple task force and work groups. And we've done a lot of thinking about how to engage specialists in accountable care. And we convene a forum every year, and the last 2 years, that has been the topic, and specifically around engaging specialists. And so some of the takeaways and conversation have been in these arrangements. It's important to think about how do you identify a high-value specialist, or in this case, a cardiologist. That continues to remain a challenge, and I'm sure we'll be talking about some of that today. And how do you structure risk sharing when, in fact, currently specialty care and cardiology in particular is primarily RVU-based. And then when we think about things like performance measure selection and attribution and accountability, how do we define that? What is the level of accountability, and how do we cascade that accountability from primary care to specialists? Other areas that we've talked about in particular is in the need for flexibility, not just due to geographic variation, but also thinking about innovation and disruptors and how that is going to continue, and how do you incorporate that into, thinking about how to engage specialists. And I guess a few final comments, and I know we'll be talking about this further, is really there's a need to think about how to move from RVU-based contracts for specialists, and then I'm sure we'll be talking today what are the payments. The current sort of retrospective attribution and shared savings models really doesn't clearly show the specialists a path forward, and what other payments are to think about. And then really thinking about the balance. You want the clinicians to be busy, but you don't want to be paying them piecemeal for activity. So how best to manage that? And then when you delegate care to the specialists, which Ann brought up, and I heard a bit in the PCDT conversation, how do you define those relationships, and how do you define who is primarily going to be responsible for the care? So I'm going to stop there and look forward to the conversation.
Thank you so much, Paul. That was very helpful. Lastly, we have Dr. Adam Weinstein, who is Chief Medical Information Officer at DaVita Kidney Care. Adam, welcome. Please go ahead.
Yep, thank you, and thank you guys for having me back. And I actually think it's very opportune to have gone third here, because as Ann and Paul pointed out, some of the high-level questions that are, I think, on all of our minds. Nephrology is, I think, a great example of how some of these problems have manifest and some of the solutions have become more evident. If you could go to the next slide for me, please. So I'm not only the CMIO at DaVita, which is one of the two largest vendors of dialysis in the United States, but I'm a nephrologist from Maryland, and I come to you today representing my colleagues in nephrology. I do a lot of work with the Renal Physicians Association, which is an advocacy organization for nephrologists worried about payment and relationships between nephrologists, patients, and the greater structures in which healthcare delivery is, I guess, delivered. Anyway, I think taking a few moments of my introductory time to illustrate what has been now probably a 15 to 20 year endeavor within nephrology to help manage the cost that Ann rightly pointed out, which is 6% of Medicare payments go to dialysis and advanced chronic kidney disease patients, is, I think, a good way to start what questions and discussion will happen next. So when we think about chronic kidney disease, I think of really complex chronic disease management. More often than not, the kidneys are a final common pathway of so many comorbid conditions. And when we think about our patients, we start in this population about 30 million people who are identified as having chronic kidney disease. Only about 500,000 at any given time end up on dialysis. We stage this with lab data, which is very handy since it's objective, measurable, reproducible. And what happens is that in our patient population, there is a shift. That is, as their kidney function declines, we, the nephrologists, take over a more intense relationship with the patient, and there is a point of handoff where we become more of the primary coordinator of care than other folks in the patient's panel of providers. We also know that there's a window of time, as you can see, where there's the greatest opportunity to mitigate potential costs and yield better outcomes. And after that window, it gets very expensive and very complex for the patient. And our goal as nephrologists, ideally and doubly so in the various payment models that we've been working with and working in for the last 15 to 20 years, has been to get people through that period such that we mitigate whatever high cost events there are. You can see that there's lots of work to be done, and a lot of it comes in terms of patient education. It comes in identifying patients that are highest risk for progression, and then doing what we can with evidence-based and other kinds of activities that would result in mitigating both the cost and quality curve. And then you can see we become the accountable provider, especially as kidney disease advances, but we are not the only provider. Our patients typically touch numerous specialties, and ultimately, I view myself as basically a project manager in complex care coordination. If you could go to the next slide, please. I think it's also worth pointing out that there are numerous variables that happen, and while that idealized model that I showed on the previous slide is what would be true under the best of circumstances, the reality is that all healthcare is local. And so urban, suburban, rural communities all have their own challenges. We have workforce challenges within nephrology, as I know we do throughout all of healthcare. As a chief medical information officer, I'm acutely aware of the tech and the data problems that exist, especially in specialties like nephrology, where we have dialysis organizations, transplant centers, and independent nephrologists, some of whom are employed by hospital systems, some of whom are not, all trying to coordinate across multiple systems. The practice transformation elements of value-based care are critically important and yet also underappreciated in many of nephrology practices. And then lastly, we too suffer from, I think, a dearth of opportunity to really share responsibility across the multiple needs that our patients have. I have included an appendix that I will not go through with you guys, but those are slides that I tend to use when talking about this, given the, I think, long-standing relationship that nephrology has in the value-based care community. So with that, I will stop and look forward to further discussion. Thank you.
Thank you so much, Adam. This is going to be a really rich discussion. So next, we're going to dive into some questions we have for you, and then time permitting, committee members, you'll be able to ask questions if we have time before noon. So let's get started. First, we want to understand care coordination for different types of providers. What approaches are currently being used to facilitate coordination between primary care and specialty care providers? And what challenges exist related to improving specialty integration? Let's start with Anne.
Thank you. So I think you raised one of the challenges that I think many of the speakers alluded to. We really don't have sufficient data to really understand not only the cost, but also the quality of specialists that primary care has the opportunity to refer to. So we obviously need to enhance the data that we have available, and that needs to be available in real time for primary care to be able to leverage so that they can make the best possible recommendations in terms of specialty referrals. We, I think, have seen that some organizations are using tools to help specify what kind of information should be transferred when there is a referral. And I think we can appreciate those kinds of tools and look to see them become standard practice, because I think that will really help to get the right information in a standardized way when a referral is being made. It's going to be good for the patient. It's good for the receiving specialist. And I think The other challenging issue we need to work on is just the opportunity for primary care clinicians to really know the specialist network that they're referring to beyond data that they may have about them, but begin to deepen the relationships. I know I'm returning to an era when those relationships existed, but they are absolutely critical, because when you're thinking about a patient referral, you really want to bring in both the quantitative information you may have and also the qualitative. I'll stop there.
Thank you. And Adam.
So I think the best answer probably comes from the years of experience we've had across multiple payment structures that have existed for nephrology. You know, it's been a sore point, because you do need what I call a data wrangler and then a care coordinator to adequately keep track of and then help coordinate the various things that patients need to do. One of the pithier things that I find myself saying a lot is that for nephrologists, every patient is a project, and every project needs a good project manager. Care coordinators need to be funded. They need to be part of these events, and only with the most recent models, which is the CKCC and KCF models, which were CMMI demonstration models currently in practice as of the beginning of 2022, do we have, I think, the right financial arrangements to have care coordinators provided usually by the value-based entities that roll up across the nephrology practices and the transplant centers. In those instances, it is great, because now we have people focused on essentially the Gantt chart similar to the one I showed that says, where is a patient in this pathway? What are the next steps? What are the gaps and outliers? The struggles continue to be, however, patients don't like to pick up the phone for people they don't know, that there needs to be a relationship between the coordinator and the patients, as well as the coordinator and other specialists. The funding that we have is helpful, but you're talking about a ratio where a coordinator might have a panel of 300 or 400 patients across numerous communities. Often they're centralized, and those folks may not know the local conditions that any patient is experiencing. We have had challenges getting the attention and time of other specialists who don't understand why there's a care coordinator for something specific like kidney disease as well. Nevertheless, it is probably the most hopeful I've been, given the fact that we now have a role and people doing these activities, and we are better defining what those tasks are, in addition to what software and other data tools they need to perform those tasks.
Thank you. And Paul.
Yeah, I would say in my experience, a couple of things. One, I would certainly echo what Adam said around care management. We have certainly leveraged, we've built a large care management team within the organization, and they certainly, we have been leveraging their expertise and their ability to help with care coordination. As well as, you know, in our organization, we have quite a large number of advanced practice providers in the system, and they also, I think, have been very helpful. For the specific communication between primary care and specialty, I'd say we've really worked hard on e-consults as a way to really start that conversation early, so that primary care may have questions about, you know, is this anywhere from, is this an appropriate consult to, you know, what tests should I order before they come see you? Those kinds of things have really enhanced sort of some of that efficiency. You know, we, I think, like many organizations, still have a tremendous access problem. The demand for both primary care and specialty care is really continues to grow. And so being more efficient, and again, using sort of the e-consults within our organization, I think, have been helpful not only for initiating information or the reasons for the consult, but then the decisions around, you know, how sort of involved the specialist needs to be in an ongoing way versus sort of making an opinion and sending them back to primary care. So I would say that we continue to, you know, I think, work on that. That has been particularly helpful. In terms of the challenges, and I'm sure we'll be going back to this, it's still, you know, we're in fee-for-service, RVU-based system where that is how, physicians generally and clinicians are paid within the system. It's already been brought up, and it makes it hard to have the time for the clinicians themselves. So we think of ways, even within the current system, so that the time they do have, they can really focus on the clinician work and then provide others to do the other work around coordination. And then how do we move that as you're thinking about new payment models where all of that would occur together?
Very interesting. Technology accelerators and continuity and relationship connectors. PTAC is particularly interested in advanced primary care models and accountable care organizations. Can you tell us how advanced primary care models and ACOs can encourage specialist engagement? Adam, let's start with you.
Yeah. So, I think the disconnect for nephrology has been that there's not been, outside of organizations that are vertical like hospital systems where Paul is operating, to connect independent nephrology practices with ACOs without some sort of contracting mechanism. And so the way the world has evolved for nephrology is largely separate from ACOs for the most part. Having said that, I think sharing the risk across the disease spectrum ultimately results in what you're looking for. It's hard, though. It's hard. The challenges that I've seen is that at some point, as in the chart that I showed in my introductory slides, there's a point where you're beyond what I think a typical primary physician would feel either responsible for or appropriately managing, and that handoff has to be the moment. There's probably opportunities upstream from where that handoff moment is to use things like e-consults and a more informal kind of process of engagement around risk reduction and risk mitigation to offer some sort of financial relationship between an ACO and specialty physicians. However, they're all employed by the same organization, it becomes a lot easier, probably for all the reasons you can imagine.
Thank you. Paul?
Yeah, I'll just add a few comments. One is the point about sharing the risk, I think, is important. And also, as these relationships are developed or established, it can't be overly complicated or burdensome in terms of understanding the relationship, and because I think that would be a particular challenge. So I think particularly understanding who the patients are, who are you're accountable for or attributed to collectively, and then defining, either through care pathways, guidelines, et cetera, who will be sort of managing, what the specialists will be managing, what primary care will be managing. I'll stop there. Thanks.
Thank you, Paul. And Anne?
When I think about ACOs and the MSSP program, the largest ACO program that we've got in the country, we're still paying primary care on a fee-for-service basis. And I think that we are not then leveraging what primary care could do if it was, paid on a capitated basis. And we are advocating right now for a capitated option within MSSP to be able to build out that team that would include a care coordinator and be able to manage more of the care at the primary care level with a team. I appreciate and this is not at all to denigrate the absolute importance of specialty care and its relationship, within the ACO and the like. But I do think, and I know I've been making this point a couple of times, that we are really so underinvesting in primary care that it is perpetuating a lot of the problems that we have with our fragmentation and the challenges with care coordination. A report that some actuaries did at Wakely examining data from the MSSP program showed that ACOs that have more primary care physicians have more utilization of EM services, and the low revenue ACOs, which we've seen in the past, do much better with respect to reducing costs. So I think, when we think about the MSSP program, and we know CMS is very interested in growing this program, I think there's a lot of data that suggests we need to strengthen primary care. I completely agree about e-consults, and we used to have that more informally, and now we can use technology to help support that kind of dialogue. It helps also to reduce perhaps the patients in the specialty waiting room that don't need to be there, that really could be taken care of in the primary care setting, to free up the specialists to see folks that really need to be seen, and allow for that management. Patients like it too, because they would prefer not to be going to lots of different specialists, but getting their care in one setting that is more coordinated and integrated. So clearly I see the MSSP program as with some changes really being able to enhance our ability to coordinate care. I think we can also look at lessons that are emerging from the ACO REACH program.
Thank you so much, Ann. I'm actually going to turn it to the committee next. I know you have great ideas and questions, and so if you have a question, please put your name tent to the side. And for our colleagues that are on Zoom, please raise your hand. And I see Larry has a question. Larry, please go ahead.
Thank you. Great presentations. Something we heard last year repeatedly was that primary care is best provided proactively, high-touch, proactive primary care. And I think this applies to the specialty space as well when they're participating in the cognitive side. I'm in reference to your care coordination comments, I am not hearing anything in the proactive role. So early detection of disease is more cost effective, less morbidity to the patient. What are you doing in care coordination to build proactive high touch care?
I think that question is directed at me, so I'll give it the first shot anyway. Could not agree with you more. And, the earliest advanced primary care models, like the patient-centered medical home, was very focused on proactive care. So analyzing your population to understand what conditions they have and proactively reaching out to manage. And, I think the ACO models help to incent that, as do these other primary care models. We know that practices, to be able to do that successfully, need the data and infrastructure to manage. And so what we observe is, a lot of aggregation to avail practices to avail themselves of that data and the like. We also see aggregators coming in to the marketplace, like Agilon and the like, that can provide that data to independent small primary care practices so that they can actually manage patients proactively. So I think your comment is spot on, and I agree with you. And we need additional support for those practices that are providing care to the safety net, that may be in rural areas that really are not well set up to provide that kind of care.
Paul, did you want to comment on that as well?
Yeah, so I was just going to add, thanks for that question, Larry. When I think about that proactive care, I really think around the virtual care. How do you manage some of this through technology? Because everyone has very busy practice. It's hard to do a lot of touches, or to challenging around doing more and more touches in person. Two examples, one around hypertension. So, we provide, through primary care, provide blood pressure cuffs with Bluetooth capabilities to the patients their blood pressures are brought into our EHR. And then those where it's out of control, the primary care physician or clinician will look at it. If they need help from the nephrologist or the cardiologist, they reach out. So again, an example of how to proactively have high touch, for a very common condition in which we're really not that good at in terms of managing overall, in terms of control of blood pressure. And then at at sort of the more specialty level, I think heart failure is a good example where, again, we leverage, and I know many organizations do, remote patient monitoring to really proactively touch patients. And, that has led, at least in our organization, we have less ED visits, less hospitalizations, less readmissions. Again, I think those are examples of how you do high touch both in primary care and in specialty to better manage these patients.
Thank you, Paul. Adam, did you want to also comment on that, or should I go to the next question?
No, actually, I think I have some value to add here. And so I would say that for nephrology and for the work that I'm seeing done through the nephrology community, the proactive care really comes in the form of the project management I made reference to. That is, we generally understand the trajectory of high-risk patients, which are typically identified through risk models that have been borne out in the medical literature. And then once someone gets into a nephrology practice and they're part of one of these programs, the idealized version of the story is that the care coordinator screens across the at-risk population looking for patients who have not had the events that you would expect. So frequent office visits, the appropriate lab measurements. And then when at the nephrology, at the practice level, that is when you're walking in the exam rooms as a nephrologist, there really is a checklist of items that needs to be considered irrespective of whatever else the patient is bringing to that appointment. So is the patient on an ACE inhibitor, an SGLT2 inhibitor, et cetera? And so there's this tension in my mind with, how do you support the necessary time and space for practices and physicians to do the value-based care work between the fee-for-service appointments. And right now in nephrology, that accounts for maybe 10, 15% of the revenue. And so to ask a nephrologist or any physician to say, I'm going to block an hour or two a week to look at my patient panel, to make choices about them between office visits is the struggle that I see. But you're absolutely right that proactive sort of iterative management of patients with a known disease progression is absolutely the only way to mitigate the cost and the outcomes.
That's so interesting. The anticipatory management piece, so important with disease, but also social determinants as well. We have Angelo, then Jim, and then Chinny. Just wanted to let you know I see you all. Angelo, please go next.
Yes, thank you. So there's been a lot of discussion about increasing primary care payment, and so I'm interested in maybe starting out with Ann, but in everybody's opinion, how would you structure that? And would it be just an increased fee-for-service payment, or would you link that to some PM for some function for becoming a project manager, for doing, and how would you link that to helping integrate care for the patients?
Well, thanks so much for that question. I don't think the answer is more, higher fee-for-service payment. I mean, I think what we need to do is move to prospective payment and a preponderance of prospective payment. A study by the Harvard Center for Primary Care demonstrated that a primary care practice needs to have at least 60% of their revenue coming through a capitated model before they feel comfortable enough to build out that comprehensive team that can provide a more comprehensive set of services that could actually do the proactive management of folks with congestive heart failure, asthma, diabetes, hypertension, whatever it is. And it takes a team, not a teamlet, not just a doc and an MA. It actually takes a team to successfully manage patient needs, because there's not one need. There's multiple conditions. You need to be also focused on mental health. If we're really going to meet patients where they are, there are many, many needs that they have. I think project management is a really good definition. I often say general contractor, quarterback, whatever it is. that's a lot of data, and that's even before you get into all the data that could be coming in through remote monitoring, which is wonderful, but it's also a lot of data, and it's not yet information, that's turned into a dashboard that can really help the primary care team manage. So, I think there are innovators out there that are doing this, and we can look to them. And now we just need to figure out what are the policies to bring that innovation to scale. And payment is a critical lever.
I just had a couple of comments on that, just to follow up. Certainly prospective payment, I think, is where we need to go. Again, I'm old enough to have lived through the HMO and capitated days, which, I bring that up only to say you need primary care or whoever to be prepared. I'm not sure many were back then. All of a sudden moved to capitation and this sort of gatekeeper model, and it led to a lot of challenges that we don't certainly want to repeat. Angela, you mentioned for some, the PM, and we saw in a lot of the PTAC models that were brought before PTAC over the years, a way potentially to enhance payment to primary care, understanding that, they will be responsible for, the management, and, there were different ways that those were constructed, whether they were sort of based on complexity, et cetera, but a way for them to start supporting the teams, as Ann has brought up, that are needed, as well as the technology, innovative technology that's likely needed, as well as the data infrastructure. So for many, there may need to be sort of an interim before getting to a full prospective, and having sort of the PM may be a pathway for that.
Adam, would you like to comment?
Yeah, I think the only addition I would add, because I agree with Ann and Paul totally, is that it's important to bear in mind that many of the physicians who are the spearhead of these events are part of a practice that has a certain business structure. And to Ann's point, there needs to be some sort of magnitude of reimbursement that's coming in the form of these PMPMs, really to shift how the practice operates. And so within the nephrology community, one of the struggles we see is that, you as a practice sign up, but any individual nephrologist or advanced practitioner in the practice is still under what is essentially a contract for fee-for-service work. And as a result, there's a disconnect between what the practice is now doing or trying to do and what the physician is incentivized to do within their work world. And again, this gets easier perhaps in certain organizations where you have flexibility around that, but even employed physicians in large hospital systems have work contracts that have dictates largely around RVU generation. So at the end of the day, whatever you decide to do in terms of a payment model, you do have to, I think, to Paul's point, expect a transition period of reasonable time frame, because the thought of rewriting every practice employment agreement is a nightmare, though I'm sure there's lots of lawyers who would be very happy with that activity.
That's a great point. Jim, please go ahead.
Yeah, thank you. I'm intrigued by this, the larger overarching concept of relationships between numerous stakeholders, relationship between the patient and the primary care doctor, the relationship between the patient and the specialist. In our market, as a large PPO market, by and large, patients will see both relationships as vitally important to them. And then we've kind of pushed an ACO model in the middle there. And so we're trying to, so to speak, mediate a relationship between the primary care doctor and specialist because there are a lot of factors that have been kind of breaking us down into silos. I agreed with the comment that somehow the PCP, increase in PCP payments, oftentimes, if we did that, whether it was through a PBMPM or some other mechanism, oftentimes the PCPs see themselves as being less compensated than their colleagues in the specialty space, and would not necessarily reflexively put that additional payment into services for the patient to create patient-centered care, with the key elements that you've mentioned, Dan, which were navigators, coordinators, relationship builders, STOH interventions, behavioral health coordination, things like that. So I think that some of the new payment structures, I'm curious about whether or not some of the new payment structures would be, again, what was commented on earlier, tied to new services from primary care. But the question I really wanted to ask was to Paul, and because I thought, Paul, because of your comments with regards to 5,500 MDs, physicians and mid-levels and such in your system, 20% were PCPs, and a 5-year history of performance financially and quality. My question to you was really, what came to my mind when you said that was how might your MSSP financial performance and quality performance improve with successful specialty engagement and integration? And could you kind of give the committee a guesstimate, estimate, or maybe some practical experience that y'all have done something up in New York that is meaningful, where this opportunity for growing the savings and the quality occurred because you did something specific around a disease condition where you intentionally integrated primary care and specialty in a new way inside of your ACO, because you have a kind of a captive employed network. I think that's a unique opportunity. And I just haven't heard anybody talk about that in a while.
Sure, happy to, and thank you for that question. So a couple of comments I'll make is when we look at our data, again, we're in metropolitan New York. Although you may view us as sort of this encapsulated provider network, when we look at our claims, half of the care for our ACO patients is outside of our organization. They're going to the other large systems, and there's a lot of reasons for that. They may live closer to there, and so if they call an ambulance, they may end up at a different institution. But having said that, it was clear when I began this work several years ago, where the high cost areas are. We all know what they are: being in the hospital, being admitted to the hospital, going to the emergency room, post-acute care. And we know there's opportunity if we really, a place to start is on coordinating care so that patients aren't reflexly going to those, particularly the ED and to the hospital, when there are other places where that care can be provided in a better setting, as well as and more efficient. So what we did, we focused on a couple of, when we started on a couple of high costs. So one was ESRD, right? I mean, ESRD patients are high cost. They represent, out of our 40,000, they're a relatively small group, but, tremendously high cost. So we looked at, where they were going, why were they ending up in the emergency room, why were they hospitalized? Again, in our center, a lot of patients, before they got to dialysis, they were they were ending up in the hospital, where then, they were going on dialysis in an emergent way. We know that's a high cost way for that all to occur. So there were already education programs in place. We work with the nephrologists at both schools. They've done a lot of work. Weill Cornell has the Rogerson Institute. They've been very proactive in early education, referring patients to transplant, but there were still many opportunities. So again, engaging between primary care and the nephrologists around not just managing the patients before they're moving towards dialysis, but then working with the nephrologists on how best to manage the dialysis patients so that they don't end up in the hospital. And so that was one. And the other was particularly around heart failure. I know I'm a cardiologist. I focus a lot on cardiology, but heart failure is a high-cost condition in Medicare overall. And we found that patients were ending up, again, in the ED and in the hospital, where we could potentially manage them better through an outpatient setting. So at any rate, so those were two particularly high-cost clinical conditions where we started, and we've expanded since then. And then I'll finally say that we focus on any Medicare patient who is discharged from the hospital. Any Medicare patient who's been hospitalized, is what I'd say a higher risk patient, beneficiary, and they're obviously at risk for readmission. And again, unfortunately, things are still somewhat highly fragmented. And so really helping coordinate and do high touch, as Larry was referring to, for those patients, we found a lot of opportunity to, reduce readmissions back and coming back to the ED. And then I'll finally say about post-acute. Again, there's a tremendous number of post-acute facilities within metropolitan New York area, and identifying partnerships and better care coordination in that area has also been particularly helpful.
Thank you, Paul. Adam, I saw you shaking your head. Did you also want to comment?
Yeah, I'm actually quite familiar with the Rogerson folks, and they are as good as Paul says. But it's a great example of where when you have organizations that are, I would say, more vertical and more integrated, you have the opportunity to agree on common standards. When do you refer to a patient? When do you refer a patient? What is it that the specialist would expect of the primary care physician versus what would the specialist want to handle? And this is where the local relationships really do matter. And so, unfortunately, there's no one universal way to apply this just through payment, but also through the education and the encouragement of developing those kind of standards within a geography or within a set of institutions.
Thank you. And Anne, are you okay if we go on to the next question, or did you have something key? Okay. I have next Chinny, and then Jen and Walter. Really rich dialogue. Chinny, please go ahead.
Hi, everyone. Thank you for speaking and being on the panel. This has been great. My question is to Paul, Adam, specifically around specialty compensation. Paul, you had mentioned the e-consults that you're using in your ACO. And one of the things we struggle with is on the path, if it's not entirely a total cost of care payment mechanism, how do you envision compensating specialists for e-consults, or having that be introduce parity to what specialists get compensated outside, right? And so not incentivizing in-person care or other sort of procedural interventions.
Yeah, great question, Chinny. So a couple of things. There is some codes available for e-consults, but certainly not a lot. We've structured some funding internally to help promote that. So working sort of within our enterprise with the hospital and the physician groups, again, as an interim. Now, that's not going to work for everyone. I mean, but we wanted to do that because we wanted to message the importance of gaining experience and understanding around what works or what doesn't around e-consults. But I'd say right now, quite a bit of that is sort of within sort of internal funding. But, even in our last forum with the ACC, CMMI is there, and we had quite an extensive conversation around how Medicare should think about in the physician fee schedule, where e-consults, can be supported to help support this work.
Adam?
Yeah. I'm happy to chime in a little bit too. So I think, as Paul pointed out, that there is accommodation in the current fee schedule for telehealth appointments. I know there's active work ongoing about what happens, for instance, audio only, and patients that are not able to do video-based calls. I would hope that as the world develops, that this will be now standard of care. The pandemic, if there's any good things that came out of it, certainly the broadening of telehealth was one of those good things. And I hope that as we move down the path with payment around these, that will reflect probably the somewhat increased burdens that telehealth brings. I believe that it is less efficient in certain ways and often best used as a supplement, but absolutely critical in terms of getting patients who often have transportation and other issues to the specialists they need to get to in a more timely fashion.
And Anne, did you want to comment as well? No, okay. Jenny, go ahead.
Sorry, just as a follow-up, the question I had wanted to actually sort of clarify was thinking through how you would compensate a specialist for primary care to specialist consultation in order to be able to better provide sort of that care coordination. Because currently, there really isn't a huge incentive for specialists, particularly if they're not getting that in-person care and downstream revenue, to partake in that outside of some sort of internal compensation mechanism.
Well, sorry, Ginny. I'm sorry if I wasn't being clear, but we fund that internally. So we understand it takes time. The specialist is taking time to do this e-consult and not seeing a patient where they get doing an E&M. And so we have a pool of funds internally to compensate, for that time. And again, it's not a perfect system, but we needed to start somewhere. And we had to recognize that this, there's time and expertise that we're asking from the specialists and communicating back, in sort of in a shared role in managing these patients.
And Ginny, were you asking if there things could go the other direction? So primary care to be consultation to the specialists holding that continuity of care?
It could go both ways. My question was more around, if you're the construct of, if I'm a primary care physician and I wanted to have some sort of, oncology does this, right, with the tumor board, but I wanted to have some sort of coordination between myself and, say, a nephrologist or a rheumatologist, and I created that. How can we better envision payment constructs that support that?
Got it.
There were some recent CPT codes that reflected that professional to professional consultation, but these things are not well reimbursed. They're certainly not universal in their reimbursement. And I think between a time that we're, sharing risk in a way that would incentivize these kind of conversations, you're really left with a fee-for-service piecemeal / documentation level need for reimbursing those conversations between two providers, be them specialists or whomever.
Yeah, that's where I think this transition, the PMPM or whatever, you need to have some dollars that are available in a more global fashion, not the piecemeal, in order to encourage and enhance that collaboration and communication. Sorry, Ann, I didn't mean to.
Ann, please go ahead.
No, I was just going to say, let's not make it more complex, right? We have 8,000 codes, like more codes that frankly, some of these new codes aren't being used for lots of different reasons. So, how can we get to that, pot of money, that Paul's organization is putting up, because they understand it improves care and we would hope also reduces costs. How do we move and transition more rapidly so that we can avail ourselves of more creative ways to deliver care? Because I think that's what we're also all trying to do here. If we pay differently, we're going to unleash a lot of creativity for people to use technology, use different kinds of team members, think about other modalities to meet patient needs and at the same time reduce costs. I did want to make one comment following up on Paul's comment about, what happened when we moved to capitation some time ago. And I think a lot of primary care clinicians have, PTSD about that, because you're right, it didn't work well. We didn't have much in the way of data and analytics. We didn't have really good performance measures. We still have a lot of work to do in terms of performance measures. But I hope now we have more of the infrastructure that can provide guardrails and accountability. If we're going to be, and we need to invest more in primary care, we can't be taking the same amount of money going from retrospective payment to prospective. We need to enrich that payment. At the same time, we need good measures to make sure that and definition of what services will be provided as a result of that enriched payment.
Thank you. Want to go to Jen next.
I also want to say thank you to our presenters for an excellent discussion. I'd like to summarize some of the things that I've heard and dovetail off of the discussion that Chinny has sparked. And ultimately, what I'm going to be asking you is what's missing and what would be helpful from a payment or payment policy perspective. So what I heard was that RPM, or remote patient monitoring, is the way for us to perform high touch, potentially primary care or specialty care, that with that high touch focus that is potentially creates proactive activity as opposed to retrospective activity. As a patient progresses with disease, which may or may not be inevitable but can be slowed, there's then high touch that starts to transition to a specialist. And Chinny mentioned this, and I agree, I think it's a good model, and it's this idea of a multi-D approach. We have multi-D clinics. They work really well in oncology, for instance. And it sounds like, Adam, that could be, an approach in the renal care space and others. But that really requires that provider-to-provider discussion and consultation. And that ultimately, it sounds like we need a project manager for the patient in their care journey, and we need a project manager for the physician or the practice across their panel. And my team that would be listening today I love project managers, and we do a frequent portfolio review. And so, like you've described, this would be a panel review or a portfolio review. So again, my question for you all as I think about what are the costs associated with standing this up, infrastructure, what are the payments needed either prospectively and or retrospectively to engage this work, and lastly, what are the levers needed to incent these behaviors? And how do we know it works? How do we prove value? What does measurement look like? So in that model, tell us what's missing and what would be helpful.
Either one of you can go first. It's a really rich question.
Yeah, it is. So Jennifer, let me just show you asked three things about what is the cost, and what was the second? I heard the levers.
I want to give you a chance to talk about cost, because practices have to cover their cost. Maybe that's infrastructure, technology. I've heard about technology-enabled care or virtual health or telehealth. That's a cost. Then there's the provider-to-provider interaction that you've all talked about. What are the incentives? There may or may not be a cost, but it sounds like, Paul, you've created an internal process because currently from a payment policy perspective, it's not either adequately reimbursed or there's not the right incentives. And then, Adam, I heard you talk about a project manager, and maybe that's covered in care coordination, but it sounds like in your personal experience in that of your specialty, it's been inadequate to do what you believe is right. And again, that's high touch, as Larry asked a question, and complicated but important work that's not currently being valued. So thinking a little bit again about payment policy, I wanted to expand the conversation beyond just virtual health, telehealth waivers. Talk to us a little bit more about where are there opportunities.
So I'm happy to talk on this. I feel like, there's a lot of things going on in my space that might be applicable. So the first cost, I think, as you pointed out, are the FTEs that are required. At the moment, the folks that are paid for are the ones that are managing our high-risk populations that are covered by the capitated contracts, either through a commercial entity or through the CMMI demonstration projects. Certainly scaling that to an entire practice worth of patients would have some costs associated with it. I would say another cost that needs to be considered is time. None of these things can happen in 2 or 3 year increments. If we're going to do this right as a country, then we really do need to think in terms of decades. It talks about bringing new people into the practice, restructuring practices in a way that's not disruptive to the way physicians expect to be paid and expect to conduct themselves in a healthcare environment. Those things are very, very challenging and take time, which I know is often not on our side with regards to these payment models. People want to to see results very quickly. The other opportunity I see is similar to the HITECH Act. We really have missed the boat with regards to population health tools. So practices, beyond simply an EHR, need the appropriate data aggregation and interoperability tools. A lot of the data is out there, but bringing it in, turning it into discrete data elements, turning it into something that is then actionable and aggregatable using things like natural language processing, and God forbid I'm going to use sexy tech words like AI, that would aggregate information and potentially offer that up in a way that a human in the form of a care coordinator or someone else whose job it is to monitor that Gantt chart of patient progression can use in a proactive way. For instance, right now we have nurses looking at 4,000 pages worth of PDF documents to pull out the most relevant information. That's just not sustainable or scalable. And then in terms of measures, it very much depends on the disease state. For heart failure patients, hospitalizations, and ultimately appropriate use of end-of-life services. For nephrology, it's going to be things around, the timeline to progression to end-stage renal disease and whether or not you get patients listed for transplant and sort of the volume of expected versus outcomes in a chronically ill patient population. Again, these things take multiple years to develop, right? Nobody gets identified with chronic kidney disease, ends up on dialysis 4 months later. It's a multi-year process, and so you have to be respectful of that time. And then lastly, I would say the opportunity is figuring out how to get practices and physicians to restructure their business relationships amongst themselves so that you are compensating physicians within the existing business structures to do the things we want them to do in terms of value-based care management.
Yeah, Adam, that's great. I'll just add a few things. That was great. Great answer. The other things I would add, Jennifer, to your question is, really in terms of payment, you really want to move to prospective payment, as Ann brought. That's really where we want to go. But to do that, we really have to be sure we understand attribution, accountability. The clinicians need to understand who are they responsible for and for, what period of time. And really, risk adjustment, including SDOH, has got to be part of that. Whenever you think of prospective payment, you do worry about sort of unintended consequences if it isn't done well. And so I think those areas really need to be improved. And again, that's going to take time. But I think that's certainly missing. And then in terms of levers and incentives, we know clinician burnout is high. There's a lot of reasons for that. When I talk to my primary care physicians, they talk about their inbox. They're spending hours and hours and hours. And again, so again, in a more global world where that's important because that's, communication asynchronously with the patient to help manage the care. That's really important. I know there's a lot of conversations around sort of, billing for that, but that's the piecemeal approach. We need to have a more global approach. And for the specialists, one of the biggest pain points is prior authorization, right? It just takes so much to do this. So again, some of the levers, if some of the payment, if it moving closer to the premium dollar for those who are caring for the patients, they can think more creatively around some of this and remove some of those pain points, which are sort of incentives levers to enhance that primary care specialty relationship and move away from sort of the piecemeal mentality.
Ann, would you like to comment? Please go ahead.
Sure. I think Paul raises a lot of technical issues that are really important to solve for. Attribution, risk adjustment, adjusting for social determinants. These are very tough issues, and there's a lot of progress we need to make here. Having said that, where I sit, I see a primary care platform that was really hit hard during COVID. Estimates of losing $15 billion in 2020, money that, primary care doesn't really have. And so when I think about where should we prioritize additional investment to try to address this issue of fragmentation, I think it is primary care. And the Europeans pay twice as much, they invest twice as much as we do in primary care or more. Not that we don't have access issues in specialty care. We certainly do. And this is not, there's differences, of course, in the salaries, but I'm really talking about the infrastructure support and the teams that need to be built out to truly provide the kind of care we're looking for. So it's a comment about, there's many competing demands and everything is costly in our system, but we clearly are spending a lot more downstream, and that increases, and a lot less upstream. And look at our outcomes. We were 4 years behind the Europeans in terms of life expectancy before COVID, and now we're even falling further behind.
Paul, did you want to comment, a follow on there? I saw your light go on.
You're asking me, or so? I'm sorry.
Yeah, I thought I saw your light go on. That's okay.
Okay.
Let's go to Walter next.
Thank you for our panelists for such a rich discussion so far and adding so much value to our discussion on specialty integration. I think we all know the goal, right? The goal is to move 100% of Medicare beneficiaries into some sort of value-based relationship with a focus on total cost of care. The current state is, and we've heard this not just from our panelists, but also from our subject matter experts last year as well, specialty care in large part today is compensated via fee-for-service RVU mechanisms. And so I think the really tough nut that we've been trying to crack through this public meeting is how do we construct payment models that appropriately incent specialty providers to participate in a total cost of care based world. And I guess I'd just like to try to get some specifics of maybe best practices our experts have seen out in the industry in their respective organizations or industry groups. So, for instance, Adam, what kind of payment mechanisms have you seen out there that will incent a nephrologist from delaying progression of, or maybe even preventing progression of chronic kidney disease to end-stage renal disease requiring dialysis? Paul, you mentioned in your ACO that You
can hear us, Ann?
Now we can.
Oh,
yeah.
That's great.
Yeah, you're back.
Wonderful. Well, it sounds like you had a really interesting conversation while we were connecting. We're very sad that we heard that. Walter asked a very good question. Do you want to do a very quick summary of that question, Walter? And then we'll go to the panelists to answer.
Sure, yeah. Kind of the premise of the question was specialists are still in a fee-for-service RVU world. We're trying to move to engage them in a value-based payment world, especially since they account for the majority of the cost of care. And I'm looking for specific examples that have worked to kind of promote this payment transition. So I asked Adam, for example, how does a nephrologist get incented to prevent progression of a chronic kidney disease patient to dialysis when the nephrologist gets paid more for dialysis? I could ask the same of an oncologist and prescribing chemotherapy infusions on a kind of fee-for-service basis, and how do you incent that oncologist to have end-of-life discussions? Or how do you, for Paul, I asked for his ACO, the hypertension Bluetooth-enabled sphygmometer device, where the blood pressure control is still mainly under the purview of the primary care, but the primary care would reach out to cardiology, nephrology as needed for improved control. How does the specialist there get paid? Is it just kind of a fee-for-service payment for their consultation, or do they actually get additional payment if they're if the patient controls their blood pressure better and has lower costs.
So I'm happy to start the answer for nephrology. So the current CMMI models, the CKCC model in particular, is a great example of how this is working. So the first piece of it is that a preponderance of the patients in a nephrology practice are usually Medicare patients, though increasingly it's Medicare Advantage. But having said that, the model allows you to have some sort of incentive payment for patients that are appropriately landed in a home dialysis modality, PD, start dialysis with a fistula, which is superior to a dialysis catheter, and then, of course, getting patients to transplant. There's total cost of care dollars thrown in there as well, so there's sort of a true up at the end of each performance period. But what really has been most eye-opening to me is that practices that assign a clinical lead and an administrative lead to help rally the troops within the practice, and to, I think, to what Paul is doing, create some sort of artificial payment structures within the practice to incentivize people's behavior in the way you'd want, is where we're seeing the greatest uptake of success. And so the CKCC model, as the years go on, we're entering, I think, payment year 2. It's a strangely structured timeline because they're overlapping measurement years. But having said that, as you start to see the data roll out, you'll see that practices that have done more toward transformation, more toward organization, more toward internal incentivization are probably going to be more successful on the whole.
Yeah, I'll just add on our, Walter, with the hypertension, the idea to what Ann was saying about moving upstream, right? We're trying to move upstream. We know if you can control hypertension, you obviously over a number of years, you're going to prevent complications. And so the way it really, so for us, it's not really incentivizing like an outcome, saying, well, if you control blood pressure. I think everyone, all the clinicians are interested in better, blood pressure control for the patients and how to leverage this. So really part of it is when is the right time to refer to the nephrologist or the cardiologist, when, based on control or lack of control and, what medicines the patients are currently on. And so creating some of those care pathways and guidelines to help has helped some of that. And again, we do have sort of some internal funding to try to encourage that communication. And again, that's trying to work within the current fee-for-service. And then there's opportunity even with chronic care management fees. There's small areas in fee-for-service that can help, enhance some of this work. And similarly for heart failure, we know our guideline-directed medical therapy, the number of patients who are truly on the right dosing and the right combinations, in general, is relatively low, and I think there's opportunity, and we've seen opportunity there by leveraging the higher touch remote communication and monitoring.
And Ann, did you want to add any comments to that?
No, thanks.
Any other questions from our committee members? So I want to thank our 3 panelists for joining us this morning. It's been a tremendously rich discussion. We appreciate your expertise and all of your dialogue. We've covered a lot of ground in this session, and you're welcome to stay and listen to as much of the meeting as you can. At this time, we have a break until 1 p.m. Eastern. Please join us then. We have a great lineup of guests for our second panel discussion of the day, and we look forward to seeing you at 1 p.m. Thank you.
Produced by the U.S. Department of Health and Human Services.